Pat touched on this slide. I wanted to point out that we really believe this is kind of the big three, if you will, things that are going to be happening in proton therapy. First, the cost reduction. We think then around planning, where we believe that planning will be automated and more automated and allow for better and more consistent planning in the future with protons as people learn and learn more. And then we think flash is going to be a big impact, as we've already started to point out. Pat also showed this slide. He went over it very, very fast, but what I wanted to point out were two things. The first is we announced a flash consortium back in late 2018, so that's only about 15 months ago. The topic around flash has exploded since that time frame, and we've been granted 5 patents, but as of yesterday we got our 6th patent around proton flash therapy. This is a picture of the consortium group. We've had 2 meetings of the consortium. This was that last PT-COG. You may not be aware of what PT-COG is, but PT-COG is the proton therapy conference that is kind of an annual conference around the world. In this particular case, it was in Manchester, and you can see a picture of the group there. This next list is a list of the current members of the consortium. What's important about this list is the members that you saw at Manchester were about 17 members. The 18th member is actually the group out of Busan. You saw it just a few seconds ago. Pat went over a lot of data around Busan, who has been a real pioneer in flash research on the electron side. And so they are now partnering with one of the consortium members in Switzerland, PSI, to allow them access to protons to continue that research and be able to duplicate that in protons. We have a number of ongoing studies. The consortium is involved in, obviously, tumor control studies and tissue toxicity studies. And you can see that we are looking and are interested in a number of different areas: lung, GI, breast, glioblastoma, head and neck, and melanoma. And we are working on, obviously, both the tumor control aspect of it and the toxicity side of it to try to learn and understand why flash works the way it works, and to try to understand some of the clues as to what will help us in the research going forward. What I'm really up here to do is to try to help you understand what we're doing from the equipment side and from the delivery side, treatment side of flash. It is a new therapy. So given the fact that it's a new therapy, it's not just about delivering a really rapid dose rate, right? If we do an ultra-high dose rate and just hand that over to you, we may hurt patients, we may do some other things that will not help this therapy move forward. And so what we care about is the mechanism of action. Why does it work? How does it work? We care absolutely about patient safety. That's number one in what we're doing and why we do it. And then the economics and advocacy around it. And you can imagine if we introduce a whole new therapy where you're treating a patient one time in less than a second, what that means to people like your government institutions that care about controlling that and understanding that, and what that may mean even economically to you as a center. The number of patients you will treat, how fast you will treat it, the convenience of that to a patient. So we've done a number of mouse studies. You saw a lot of the results from the mice, but we actually treatment planned those mice using standard treatment planning. So we used our Eclipse treatment planning to actually plan those mice to be able to help us prove out how we could do this type of planning. We also have now pushed forward looking at what will plans look like when we do humans. So when we get to human testing, when we get to clinical trials, how do we make sure that these plans are both flash capable but also dosimetrically, are they good enough? Are they conforming at least to the standards that we hold today? And what we found already is in the initial studies is that we can deliver these flash dose rates and still be very conformal to, again, help with some of the patient safety early on. One of the things that is very important when we talk about flash is when we talk about dose rate, many times people are thinking about the dose rate in the Bragg peak. So Lei Dong did a very good job of defining what we mean about the Bragg peak and how we do a spread out and so on. But what's important is to make sure that we understand what the dose rate is now in the healthy tissue, not the dose rate in the tumor. What we found is the dose rate in the tumor, at least today, that doesn't mean it isn't going to change, but today we found that the dose rate does not seem to make a difference in the tumor. But it does make a significant difference in the healthy tissue. So what we care about is in that plateau region, right? What's the dose rate in that healthy tissue? So to help us, we've also started designing and started implementation of now giving you a visual on dose rate, right? We've got a visual today. You typically have your dose wash and dose understanding in the tissue and in the tumor. That's what you're used to. What you need to get used to or an understanding of in the future is what's the dose rate wash look like in the healthy tissue and in the tumor. Okay, and so that'll be a whole new paradigm for us to learn to care so much more about dose rate than we do about dose. And if I can get this, sorry. We have recently, it was just in November, I believe, we did some studies where in Cincinnati at the Children's Hospital there, we actually did some phantom testing where we actually ran through the actual flow and patient flow using a phantom. And so we've actually run now flash phantom tests on the actual system itself in a treatment room. And then we have also already designed and prototyped one of the things that is most concerning, which is how do you measure this dose rate when you are delivering this to a patient. And in this particular case, this is a new ion chamber that allows us to measure both the dose rate and positioning of the actual beam itself. And we've been able to measure that up to about 230 gray per second. Okay, so just, again, you have to understand the difference in where we were at about 1 gray per second, now measuring all the way up to 230 gray per second. And I'm actually going to end here with a very short little video. This is actually a video of the delivered dose of 18 gray at 100 gray per second in 180 milliseconds. Okay, so this is, you're going to have to watch it quickly here, because I'm going to hit the button, and then you'll watch it deliver the dose. I hope it does. I hope it works. I haven't tried it yet. But here we go. Okay, so you just delivered 18 gray to that target, right, in a patient in split seconds. So that's how we will deliver flash in the future. That is obviously just one field, but that's what we intend and believe. We've got very promising results that we're seeing. As Pat mentioned, we are committed to the FLASH program, and we really invite you to be part of that. If you notice the map that was shown early on when Jean-Luc showed the map of where the proton centers are, there's a big, huge gap in Russia that we'd like to see a lot more of. So we really think that FLASH is going to enable a lot of things. I also wanted to point out that, remember, when you buy a system, you have a very good proton system, and now the ability to potentially do FLASH in the future. So it's not just FLASH only, and we don't think FLASH is going to take over the world tomorrow. but we do think that with protons and the match of the ability to do flash, we think it's going to be very important.
Скажите, пожалуйста, какие датчики дозиметрические можно применять вот при таких огромных мощностях дозы?
Yeah, this is really the slide, if you will, that talks about that measuring, right? We have the ability now to use a new design prototype ion chamber that allows us to measure those dose rates now at these very, very, very high dose rates. It's new, it has had to be designed to do that, but we now have ionization chamber. This can do, the size that this can do now is we can measure across about a 40 by 40 centimeter area.
Опухоль – часть организма. В чем вы видите различие между опухолью и нормальными тканями для вот этой вида терапии? Сначала шел разговор о том, что поглощается кислород, как бы, роль гипоксии. Сегодня нам рассказали о том, что другие гены начинают отключаться или работать. Ваше собственное мнение, в чем разница между опухолью и организмом нормальным?
That's the we call this the $1 million question. It is.
I have my own already.
Yeah. We wish we knew the answer to exactly that question. Right? Why is a tumor responding different than the healthy tissue in FLASH? It's been the most difficult thing to both determine, and it is the one thing that every researcher is trying to find. We do have theories. As you mentioned, there are some theories around oxygen. There's some theories around the different cells that are acting differently in both tumors and in healthy tissue. And we're also seeing a difference in the immune response to both the healthy tissue and the tumors. Do we have an understanding of exactly what that is? No, we do not. We have a much better understanding of why the healthy tissue tends to be spared because of the oxygen. So I'll give a quick explanation. I'll try. With oxygen, if you deliver the treatment in, let's say, 60 seconds over a treatment period, the replenishment of the oxygen in those cells is ongoing, right? So you're creating more and more oxygen with particles hitting, of course, and then the ability of that, it creates what we call radicals, right? Radicals that will damage the tissue. The more and more that happens, meaning the more replenishment, the more oxygen, the more possibility you get more damage. In a split second, if we deliver that same dose, the oxygen gets absorbed quickly, but then it's over, right? So when we replenish the oxygen again, we do not see the radical development. So less tissue damage. Now that's a hypothesis. That's a working hypothesis that the Lusan group and some others have actually identified.
Касательно кислорода, но в опухолях есть гипоксия, поэтому там этот метод должен защищать клетки больше, чем клетки нормальных, хорошо оксигенированных тканей, что прямо противоречит тому, что вы показывали. Это одна вещь. Вторая. Если взять плотное ионизирующее излучение, альфа-частицы, то там нет зависимости такой от наличия кислорода, как для редко ионизирующих протонов. То есть там безо всякого кислорода мы имеем меньшую защиту гипоксических клеток.
2 миллион получили.
Yes. Yes, again, the issue is although there is a hypothesis around healthy tissue on oxygen, it is contradictory, as you mentioned, right? It's contradicting in the tumor. And so that is what is puzzling to many of the people in science, right? Is why is this still controlling the tumor? And again, we may see a balance by, you know, the immune system or something else that's acting to counter that protection, or we may see just a very, very different response at the micro level in the genes themselves. Again, we do not have that answer, and you're absolutely correct, and I'll need at least another $1 million.
Есть ли возможность улучшить уже имеющиеся центры протонной терапии для применения ФЛЭШ-технологий? Или нужны какие-то специфические, то есть нужно ли строительство каких-то дополнительных структур?
No, we think that the current equipment that's out there, that's already developed, is capable of both flash and doing what we believe at very, very high-end flash capabilities. This is not the only machine, right? There's going to be other machines that can do this also. I think we have to learn and understand much, much more about what's causing the effect before we can really change the machine or change and develop machines that are going to be able to deliver flash in the future. The beauty is we have machines today that are capable, so it allows us to learn, it allows us to start to treat patients today. But I think in the future you may see flash-only machines as possibly designed that would be very, very different than what we know today.